Washington's injury-plagued season got even worse this evening after Jayden Daniels suffered a gruesome-looking left elbow injury on this play. And in this video, we'll take a look what exactly happened, how this injury is going to be managed, and why he actually might, in fact, still return this season. Welcome back, everybody. I'm Dr. Brian Sutterer, and the goal in this channel is to teach you more about the medical side of the sports world. So this is an injury we have not covered very often at all on this channel, certainly not this year, or I think anytime in the recent past. This is going to be an elbow dislocation. So here as we see Daniels come down, he's going to land on an outstretched arm. We call this a foosh, fall on an outstretched hand. Not necessarily the classic fully extended wrist position, but in this position, when you are landing, depending on the exact angle of flexion in your elbow is going to try to bend a little bit to absorb some of the blow of landing on the ground. But if the forces are transmitted in an abnormal way through the elbow, typically when the elbow hyperextends, so we've seen knee hyperextensions, the elbow is a similar hinge joint with a rotational component from the radius. But whenever you land on a straight elbow, that elbow can extend in a way that causes it to hyperextend and ultimately lead to failure of the surrounding ligaments in the elbow and a subsequent dislocation. This is the view that the medical staff is going to see once they get out there that's going to tell them that there's been a dislocation. Some people might look at this and think that there's been a fracture, but what we're actually seeing here is almost certainly the olecranon, or the bump in the forearm, the bump of that ulna that's dislocated posteriorly out of the ulnohumeral joint, causing this classic deformation where it almost looks like the lower end of the arm is kind of sunken inwards. Let's go to our biodigital anatomy tool because we haven't talked too much about the elbow joint in particular. And so I think we need to understand some of the basic anatomy here first. As I said, the elbow is primarily a hinge joint. It's going to form a flexion extension hinge between the ulna and the humerus. That's going to be the ulnohumeral joint. So whenever you flex and extend your elbow up and down, that's the ulnohumeral joint articulation that's going to be moving, causing it to bend in that direction. And so that bump that we're seeing on the backside of the elbow is going to be right here. That's going to be that olecranon process. Now, as I said, there's also a rotational component, pronation and supination, we call it. So whenever your hand is turned up, that's supination. Turning it down is going to be pronation. And that all comes from the articulation of the radius along with the humerus, the radiohumeral joint. So right up here at the top of the elbow, the radius is going to spin, allowing you to have that pronation and supination, while the ulna flexes and extends. We describe elbow dislocations based on the position of the ulna relative to the humerus. And the most common is going to be a posterior dislocation, where essentially this curved contour of the ulna completely jumps out of its articulation with the humerus and dislocates back posterior. That's going to put this depression in the skin, this sinking in of the skin from the ulna being pushed in that direction, which means to get the elbow joint reduced, you have to unlock it from what we call, it's this specific spot on the ulna called the coronoid process. That can get caught on the backside, so you have to apply traction to pull it away from those bony contours and then bring it back up into a flexed position to clear that humeral articulation and get the elbow back in its proper position. Now remember, when joints dislocate, they're going to dislocate because of failure of either the ligamentous structures or sometimes fractures. In the case of the elbow, on this medial side, we're going to have the ulnar collateral ligament. There's going to be a radiocollateral ligament on the outside, and those are going to be your two primary stabilizing structures. When we see a dislocation like this, you can assume that there is going to be significant trauma and damage to those supporting structures on the ulnar and the radial side of the elbow. The bigger concern with how we manage these is whether or not it's a simple or a complex dislocation. A complex dislocation means there's a fracture, and the most common place you're going to see a fracture is going to be this coronoid process right here on the tip of the ulna, because again, it's going to impact on the humerus as it goes backwards. If there is a fracture, that often involves some sort of extended absence, potentially surgery. There's going to be more instability in the elbow joint. If it's a simple dislocation, meaning no fracture, just ligament disruption, that can actually be a fairly quick return to playtime, especially if you're playing in a sport where you can brace. So thinking about all those structures, thinking about the ulna articulating with the humerus, the radius that's going to be rotating and spinning, as Daniels comes down and lands here, this straight arm causes all that force to go through the elbow. Probably some component of the rotation here is what led to that dislocation. You're going to have the ulnar collateral ligament on the inner side, the radial collateral ligament on the outer side, and those forces are not able to be withstood by the ligaments, causing the elbow to rotate, dislocate back posterior into a posterior elbow dislocation. I want to point out too, in this position, what we're seeing is actually the rounded contours of the front part or the anterior part of the humerus. And remember, there are going to be blood vessels, there are nerves that are running down the front part of this humerus in through that elbow joint. And so you always have to, of course, be especially concerned about damage to the nerves and to the blood vessels being pulled, being sheared whenever you have this severe amount of change in the position of the joint with a dislocation. Assuming they're able to get the joint reduced on field, which honestly, sometimes they might not be able to. There could be a large fracture in the way, something else complicating things. It looks like they were able to in this case. We see his elbow has this vacuum splint applied to help keep things nice and stable. They're going to get him off to the hospital for x-rays to evaluate for any fracture and continue to check his neurovascular status. I encourage any medical providers or students who are watching this to go search some videos of elbow reduction techniques. It's not something you're going to see super common. I've seen one in my few years covering sports in the real world. And so it's something that you should at least review a sense of how to manage these or try to reduce them. It's definitely something that you're probably going to want to have your physicians try to manage as opposed to doing it yourself just because of the high risk nature of it. But sometimes you're in situations where you don't have a choice, especially if there's neurovascular compromise where you need to get it back into a reduced position to try to alleviate that neurovascular trauma. Now, as I mentioned at the beginning of the video, there's a chance you could see Daniels back on the field sooner than you might think after an injury that looks like this. Because it's his non-throwing side, his non-dominant side, he theoretically could return to play in a brace, assuming there's no major fracture or nothing that needs surgical attention or longer term healing from a bone perspective. If this is a simple dislocation, meaning no fracture, then yeah, in the appropriate position player in a sport where you can return to play with a brace, on average, maybe 4 to 6 weeks, you could see somebody back out on the field playing in a brace. Their full recovery is certainly going to take much longer, but you can stabilize the elbow well enough to protect them and get them back on the field. Now, I don't necessarily think they're going to do this with Daniels just because he's their franchise quarterback and they wouldn't want to put him out there compromised in any way, especially the season that Washington is having. But if this was a different position, lineman, for example, linebacker, you'll often see guys return to play with a brace somewhere around that 1 month to 6 week mark, assuming again that there's no fracture. So step one, is there a fracture? If there's a fracture, that kind of changes everything. Sometimes you do in fact need surgery. It can be a much longer healing process and time period. But if there's no fracture, simple dislocation, make sure there's no nerve damage, no blood vessel damage, and then splint, brace, early range of motion and rehab, theoretically returning to play a month to 6 weeks, again, depending on the circumstance. So that's it for the video, everybody. Let me know as always any questions or comments down below. And until next time, we'll see you later.